Welcome to the Teaching Value and Healthcare Learning Network. Join us to hear leaders in the field share practical and tangible advice about how to teach and deliver high-value care. With national concerns about rising healthcare costs, as well as overuse and misuse of medical care, Cost of Care, in partnership with the ABIM Foundation, hosts an open forum to discuss ways to initiate, implement, and sustain feasible innovations in value at your institutions. I am Reshma Gupta, the Director of Evaluation and Outreach at Cost of Care, and I'll be moderating today's webinar. We are honored to have today Dr. Michael Parchman, who's a senior investigator at the McColl Center for Healthcare Innovation at Kaiser Permanente, Washington Health Research Institute. He recently led their initiative on taking action in overuse. Michael, thank you so much for coming today. You wear many hats, and our audience really focuses on implementing much of this work and messaging with frontline clinicians about how to improve healthcare value and reducing overuse. Can you take a moment to describe the program that you helped develop and initiate in overuse?
Sure. Thanks, Reshma. It's great to be here with you today, and thanks for inviting me to participate. This really began 3 years ago when the Robert Wood Johnson Foundation approached us and said, you know, we don't know much about how you engage providers in doing this work of relinquishing low-value care services. Can you help us understand how we might support providers and their organizations in dealing with overuse? And so for the last 3 years, we worked at identifying exemplar organizations across the countries who were doing this work and studying what they did. And then out of that, we built a framework we call the Taking Action on Overuse framework that describes sort of the key activities and domains that an organization should pay attention to if they're trying to engage providers, patients, and team members in overuse reduction. We really feel like the engagement piece is sort of the missing piece of the puzzle for this. And then over the last 2 years, we've used this framework to partner with 3 different healthcare organizations to use that as a roadmap or a guide in their efforts to address an overuse area, and have learned a lot from working with these organizations and watching their experiences.
That's great. Can you describe specifically with these 3 institutions specifically that you really engaged with in coaching them? What part of the health system were they working within, and what topics were they really trying to address?
Yeah, so the 3 organizations, and you can find them in a description of this on our takingactiononoveruse.org website, or the Missouri Primary Care Association. They were working with safety net community health centers in addressing opioid overprescribing. The UCLA Medical Center and medical group practice that were addressing overuse of GI endoscopy, both upper and lower GI endoscopy in their setting. And then the Swedish hospital and healthcare system here in Seattle, Washington, which is trying to address overuse of the emergency department, high utilization and high utilizers in the ED, and address overuse. So there were very different organizations. They each had a different topic they were trying to address that really required them to take some unique approaches to this. We purposely chose them because we wanted a diverse group, and we wanted to see what was similar and what was different across these 3 settings as they tried to get their hands around how do we address overuse or unnecessary services that are being delivered in our setting.
And one of the things that I think is really commonly discussed in this webinar series is that issue, knowing that many of us are implementing this work, is facing culture, the buy-in, and the engagement related to this work. And so I'm really interested to hear, how those were similar and how those might have been different between these different groups, because we have a group working in ambulatory medicine, one working in specialty medicine, and then another one really looking at a large facility-based overuse of ER usage. And so different folks need to be engaged across the board there.
Right. Yeah, there were some real similarities and some real differences. I think similarities across our three organizations is, number one, it required more resources than any of them had planned on to get their hands around how much overuse was occurring in their setting. It took longer. It took a more deep dive into their data to figure out how much overuse was occurring in their settings, and to identify the drivers of that overuse. So it was different than a traditional QI process in that way. It took longer than they expected. In every single setting, addressing overuse takes longer than a traditional QI initiative usually does. Secondly, every setting realized the importance of patient harm as a important component, a critical component of their effort to engage providers in this conversation and talking about patient harm or potential patient harm. And they all realized that data was not enough. They needed to have stories. And this wasn't just physical harm. This was financial, emotional harm, and physical harm that results from unnecessary care services, because otherwise they could not get people to the table to talk about this topic in their setting. So having patient stories and having those available to stimulate and to engage people and having these conversations was critical across all three settings. And addressing the human factor side of this was real similar across the three settings, because we're talking about behavior change, and it's a complex social process to change the behavior of providers, teams, and patients in thinking about overuse. And ignoring the human side of this, of asking people to relinquish something or asking people to do nothing, in some cases, is really critical. And it was really hard to get people to the table to talk about it in all three settings.
Yeah, so very similar kinds of barriers in a sense that the sites were facing.
Right.
And I really appreciate the fact of differentiating how this is different than a traditional QI, quality improvement initiative, because there is so much startup required, it sounds like, that these sites were facing, that we faced as well. A couple things.
Can I add one more point?
Yeah, absolutely.
One more point, which was, the people that we worked with, the overuse reduction teams in these settings, didn't have a good home base for this work either in these organizations. This was not traditional QI. This was not traditional patient safety work. And they felt in limbo, kind of in between those two areas about where does this reside within our healthcare organization in terms of doing this work of reducing unnecessary care. Is it patient safety? Is it QI? Does it occupy an in-between land, an interstitial space where nobody's doing this work, and where should it reside? And I think that's an unresolved issue.
That's a really, really good point too, because I think it probably ties to some of the resource issues. I wouldn't be surprised without having infrastructure or that sponsorship with the clear delineation. Sometimes it creates barriers or time to get data and those types of things.
That's correct. And it requires leadership at every level of the organization to keep talking about this and messaging this and saying how important this is. And all three settings, so another common factor is all three settings had turnover in leadership during the time we were engaged with them, which was only about 18 to 24 months at the most. But that significant turnover in leadership really set them back, all three of them, in trying to do this work. And they were constantly having to go back and restart efforts to engage new leadership and get new buy-in to address this issue, which really impaired or slowed down their efforts.
That's one thing that some of the work that we've done is create a survey that actually looks at high value care culture. And what we found is the greatest domain that drives most of that culture are items related to leadership engagement, messaging with leadership, infrastructure provided by leadership, visibility. So, I mean, that really, really hits home and makes a lot of sense. One thing that you brought up that I think is really interesting is the human factors and how this relates to that, because again, it's about, I think across the country, there are so many changes that we're seeing with leadership probably in nearly every institution. And as we're implementing this work, it probably is an area that, has to be planned for in advance, that some of that leadership sponsor may change over the course of the study or the initiative. What did practices, or kind of what did some of these sites learn, from their experiences, or what could they have done better in terms of that engagement process or the messaging with these different key stakeholders and leaders in organizations?
So one of the things that they learned is, like I said before, bringing up the issue of patient harm, sorry, the potential for patient harm is central to the work and engagement. But the flip side of that coin is that makes this work emotional work.
Mm-hmm.
Because then what you're doing is you're talking to providers and teams about a service they've delivered or something that they've done that might have harmed a patient in the past. And that's difficult psychologically for people to deal with. And it requires that you sort of cocoon the providers and the team and make it safe and create some psychological safety for people to talk about this issue. That's why people are reluctant to have these conversations, because you're not going to change their behaviors without having these conversations, because it requires changing the culture of how medicine is practiced in these settings. So if you're going to change the culture, you need the conversations, but you can't have the conversations if people are resistant to them because they don't want to go there thinking that they may have harmed the patient because some area of overuse they've done. Especially this moral disengagement, which is, I'm not responsible for the immediate consequence of the test I'm ordering. I'm only responsible for the immediate consequences, not the domino effect of a test I order or a treatment I gave, which is that as a result of this test or treatment, several steps down the pathway, something bad happened to the patient. Well, that's not my responsibility. So there's a moral disengagement piece here that also has to be addressed in having these conversations about overuse and getting that engagement to happen with providers and patients. And we heard those stories too, from the sites that we worked with, and how hard it is to do that. So that was interesting. I would add that data has to be credible and transparent, but it doesn't have to be perfect to start these conversations. And in some settings, they were very reluctant to even start the conversation until their level of confidence in having the data be perfect was so high that it delayed them by months and months and months and months in having any conversation about the potential for harm from an overused service, because they were so afraid of pushback from providers and staff about, oh, well, that data is not credible, it's not right, it's not us. Overuse doesn't happen in our department, it happens elsewhere, but not here. And that's problematic for many of these organizations to do that. And they emphasize that these conversations should be happening even if the data is not perfect. Because you can bring stories to the table as well. So no data without stories, and no stories without data.
Yeah, I love that. It's the story of data paralysis, right? That many of us get into across the board. And so there's so much low-hanging fruit sometimes where there's opportunities, that it is about, sometimes just getting started and being willing to make the mistake to then say, hey, we're iterating and we can change this over time. And I love that idea too about the fact that these are conversations that need that psychological space to say that, hey, we may not have been doing things exactly the perfect way in the past, but it's okay in terms of moving forward. One other thing I think that you bring up, which is very interesting, is about that messaging and how there's a cognitive dissonance with that for folks. Not only just a place of psychological safety, but also, if we're saying overuse to reduce colonoscopies, for example, that is going to potentially have some negative outcomes that are unexpected from that. And I'm wondering if you could share a little bit from not only the 3 sites in this program, but from some of your work even before, where you've seen some of those negative consequences coming from messaging on one area and one area only of overuse.
Well, one of the things we've seen, and we've talked about with our partnership sites as well, is unintended consequences are not uncommon if you're trying to reduce an area of overuse. So, for example, if you're trying to reduce overuse in one area, say test ordering, be prepared for a compensatory response in another area. You might see referrals go up. So test ordering goes down, but referrals go up. So be prepared for that. Think ahead about where that compensatory behavior might happen, and watch for it, and even talk about it when you're having these conversations about reducing an area of unnecessary care, and bring it up prospectively and say, and there's always the possibility that if we try to reduce test ordering in this area, we might see you guys have a compensatory increase in referrals. And we're going to be watching for that as well. And we want to talk about that and talk about why does that happen, and what can we do about that, right? And make everything transparent, make it a transparent conversation for that. So being prepared for that is also important. I think another area of concern that we don't quite have our hands around is whether efforts to decrease inappropriate services also has the unintended consequences of also reducing appropriate use of some of those services. Because we've seen the inverse happen. We've seen where people are performing really highly well on, say, cancer screening and referral for colonoscopy. That may also be the settings in which you see the most frequent inappropriate use of that service. So it's kind of overshooting the mark. And so this becomes sort of a Goldilocks phenomenon of how do you hit the right sweet spot of appropriate versus inappropriate testing or lab ordering or whatever the area of overuse is that you're concerned about.
There's so much fruit, I think, in what you just said there, because as many of our audience are educators or have that hat in translating these initiatives to clinicians and staff and nurses and others or residents in this field, it isn't about saying our goal is to reduce costs or our goal is to just reduce overuse in this one area. It's really to create these algorithms to understand in these situations, these are areas of when we're overusing. In these situations, this is an area where it's actually appropriate. And in these situations, it's actually of high value care to do these things to prevent further downstream, later disease progression. And so that nuance of not just having one message is really great that people out there. I really like that.
Yeah. That's really important, because what we're really talking about is making it possible to have this conversation about the culture of how we practice medicine in our setting. So the way we practice medicine in our setting is we make time and space to have these conversations about when is it appropriate and when is it not. When is it appropriate, when is it not? Let's talk about it. Let's constantly work at this. It's something we may never arrive at the perfect solution of, but as long as we're talking about it and saying this is the culture of how we're going to practice medicine in our setting, I think it's the journey that matters here for organizations.
Well, I want to thank you so much for coming to speak with us today. I think there's so many great lessons learned that you've highlighted through today's discussion that I think really brings light to how to think about being prepared and thinking through about potential negative consequences or other factors as folks are implementing this type of work, and with your experience across so many sites through this effort. So thank you so much for joining us today.
You're so welcome. And if others want more information, visit our website, takingactiononoveruse.org. We've got a lot of tools and resources there for people, thanks to the support from the Robert Wood Johnson Foundation. So thank you, Reshma.
Great. Thank you, Michael. Thank you.
Bye-bye.
Bye.